Okay, we're back. We have Paul Ingraham here. Paul, thank you so much for coming on. Could you provide a brief
Pleasure.
intro on yourself, your background, and then we can rock and roll for today?
Sure. I am the painscience.com guy. I'm a former registered massage therapist who ended up publishing about pain and rehab. While I was working as a massage therapist, I was writing articles for them, and that earned me, to my surprise, an international audience back in the 2000s. And eventually that took over my career, and I became a full time science journalist on these topics. I am in Vancouver, Canada. Massage therapy is a good 13 years behind me now since I last was a clinician. And as things go, I'm getting more and more interested in broader pain topics. I started out mostly writing about manual therapy and injury rehab, and I've spread out and also developed some of my own really entertaining chronic pain problems, which has given me a lot of empathy for my readers and given me a lot more to think about and chew on.
I don't know initially when I found your website, painscience.com, but I think it was an undergrad or maybe early grad school when I probably had typed in something around pain science or biopsychosocial and it popped up. And it's been an extremely helpful resource ever since. And even looking at it now, most recently, within the past few months, wrote an article for E3 on fibromyalgia, and your website was the first place to go to, as I know Paul has an in-depth resource, and I re-looked at it today, and it's a 110-minute read, but which is just wild. The vast amount of information you put in any specific topic and the resources you attach and the literature you provide. So thank you for being so consistent for this long.
Thanks. And maybe it's a sign of some kind of pathology in me, but I consider that to be a short and incomplete article.
Which article is the longest?
If you exclude the books, it's probably, because I have 10 books, painscience.com/books. I have 10 of those. If you leave those out, it's probably my famously skeptical stretching article. And that's really, it's, you could almost call that one a book. I haven't presented it or sold it like any book. It's a free article, but it's a monster.
And is it true, my assumption when I go through these articles is you're constantly updating them. So you won't just finish one and let it go forever. A lot of these you will even put like the date that it was last updated. Is that just a continual evolution for most of the papers and books?
Yeah, I mean, I love to hear the word constantly, constantly updating. Probably not as true as that makes it sound because I'm spread pretty thin. I have a lot of content now, and it's really hard to keep 10 books and 300 articles up to date. So I do a lot of running around, and I just there are some articles that inevitably I don't touch for quite a while. But yeah, I try really hard to keep everything up to date. And in particular, I'm pretty good at triaging. And, for instance, if I see some science that provokes me, challenges me, maybe invalidates something that I know I've written on the website, that'll just go right to the top of the list as something that I need to deal with and address, and either, change my tune on the website or explain why I'm not changing my tune. So yeah, I hope I do a pretty good job of publishing the most significant updates.
And when I initially reached out to you, I think I struggled to identify what exactly we should talk about, because if anyone has looked on your website, or they should, it's impressive how varied the topics are in the information. So trying to figure out an exact talking point today was tough, but we kind of found one, and we'll dive into it soon. But I want to start out with a little bit of the background of, you mentioned why you started it, but maybe more so a little bit of your evolution of your beliefs on the writing process, why you decided to write and look into a lot of these areas.
Yeah.
And then we can go from there.
Yeah, sure. The earliest versions of my website were published in about 2002 or 3, and I really did start out 100% writing for clients. It was like basically publishing waiting room brochures about pathologies, guides to conditions, and just expanding on the stuff that I didn't have time to cover in sessions. Partly because sessions are only so long, and partly because people only want to do so much talking when they're getting some a nice sensory experience in a massage therapy appointment. Chatting isn't always their priority. So I started writing for clients. One of the biggest changes over the years is that I now write mainly for professionals, although I really work very hard at doing it in a way that is still accessible and interesting for patients. But definitely the audience has shifted in the direction of writing for pros over time. And I think that's because I just keep diving deeper down the rabbit holes. And the further down the rabbit holes you get, the more of the lay people you lose and the more of the rehab nerds you attract. So it's just been, I think, a natural evolution. Because I was so interested in the topics, I just kept going and writing more and learning more and writing more and learning more, on and on for a long, long time now.
Hey,
Yeah.
has as that transition of audience has shifted from your own patients to a lot more providers, has your writing style shifted a lot, knowing that?
Oh, for sure. Yeah, there've been a lot of changes. A big one is that I'm far more diplomatic than I used to be. That's partly pragmatism, because I know that I'm asking people to buy books, become paying members of my website. So it's not smart to excessively provoke them. It's a very strange business model that I have, because I'm so well known for debunking and skepticism, and I am very often literally trying to sell content to people that I'm criticizing. I don't recommend this as a business model. It's unwise and strange. It's kind of a miracle that I have any customers at all. So I've gotten way nicer, but I think that as much as it's about the pragmatism and business sensibilities, I'm also just mellowing with age. I was more of a firebrand when I was younger, and the more you learn, the less you know. And I'm a lot less confident than I used to be in a lot of ways, in a good way. I'm less inclined to overconfidence about anything, because it's impossible to work with this content for long without discovering just how many different ways you can go with it. My standards have gone way up. I'm way more meticulous and rigorous, which sometimes feels like paralysis. It's harder to write an article these days because, in 2005, practically anything was good enough. And having a footnote on a blog in 2005 was all you needed to do for that to be an amazing post was just add a footnote. And everybody's like, whoa, my God, he's got footnotes. Whoa. Obviously, things have changed, and footnotes no longer quite so impressive. So it takes a lot more to produce content, because it's just really, I work way harder, way more polish. And another interesting change is that I'm doing way more audio, like, doing an interview like this, but I'm reading my content aloud. I'm doing audio versions of content, which is, it's gotten to the point where it's an integral part of the writing process. I feel like I can't produce anything without reading it out loud for the microphone. So that's another interesting change that's just in the last couple of years.
You mentioned a lot of earlier on, it was a debunking, and that just generally when you look into a lot of these topics, there's a lot of misinformation or unknowns, and you're providing what potentially is known or addressing the uncertainty. Which topic or either book or article has gotten the most maybe criticism or just like controversy because of the general nature of that topic?
I mean, there's difficult topics and then there's controversial topics, and sometimes they overlap. Sometimes they're difficult because they're controversial, and sometimes they're controversial because they're difficult. But there is a distinction. So, for instance, immunology. Um, that is a really difficult topic because immunology, as Ed Young wrote, is where common sense goes to die. But it also turns out to be critically important for understanding how pain works, especially persistent and unexplained pain. It's kind of the quantum physics of the life sciences. So that's just a really difficult topic. But then at the other extreme, something it's difficult but also highly controversial would be trigger point therapy, which is probably the topic where I've personally experienced the biggest shift in my views over the years. I was pretty much a trigger point therapist during my career. When I was a clinician, I defined myself as a trigger point therapist, and I was very interested in the topic, and I devoured, all the conventional wisdom on that, meaning, mostly Travell and Simons. And then in 2010 to 2020, I became a huge critic of trigger point therapy. But my position today is complicated, and I'm a real fence sitter, and I don't, the skeptics claim me, and the trigger point therapists claim me. They all think that I'm on their side, but I'm not on anybody's side. I think the truth is in the middle on that one, and I still think it's a fascinating topic worth considering. But I also think that the industry has serious problems with it. For every therapist who approaches the topic with humility, there's probably 100 who are overconfident at best, or at worst, they think they're trigger point whisperers and have appallingly poor knowledge of the topic.
Let's go to the main topic for today. So when we were reaching out through email, I asked kind of more recently, which topic have you changed your mind on the most, or what you've been thinking on? And you mentioned this idea of the entirety of the biopsychosocial model and potentially this pendulum swing from one region to the other, from biological to psychosocial. So maybe we start with, you laying out your current confliction in your head or your thoughts, and then we can go a little bit further down into what you're thinking.
What do you want to know about it?
Let's go. You initially said to me that you've been, not that you're abandoning the idea of the psychosocial, but
no, definitely not abandoning.
Yeah, this opinion of this overemphasis on the backlash against the structuralism and biomechanical aspect of this model, or of medicine or healthcare, and why you think maybe that's not the best idea, and why there's potentially too much of an emphasis now on the psychosocial aspect of care or of research.
Okay. Well, that's a very open-ended invitation on that topic. There pendulums everywhere in this business. They're always swinging. There's a lot of fashion in the business of helping people recover from pain and injury. And maybe the most dismissive thing you could say about care that is done the biopsychosocial way is that it has become fashionable, which is, a shorthand for saying that it's often shallow, that it's just paying lip service to it, and that it doesn't have real substance, and that it will pass like a fad. And there's certainly something to that. There have been some fairly serious problems with the application of this idea in the last while. But maybe we should rewind a little bit and talk about, what are we talking about, the biopsychosocial? What is this? Probably everybody in the business has has heard about this now. Patients, not so much. Professionals probably have a hard time avoiding it. If you read anything about this stuff, if you do any continuing education, you're probably going to encounter this idea. And the idea is, the BPS model is, the biopsychosocial model is basically, I like to summarize it as, it's essentially the idea of friendlier, more patient-centered medicine. It goes back to the 70s. A doctor named Engel, who basically said, we're getting too technical, we're getting too pathology focused. We need to do a better job of being nice human people interacting with our patients. And the biopsychosocial model of care was born, or at least formalized. The ideas weren't new. Lots of people have always, throughout the history of medicine, people have talked about this. You can find, classical quotes about the person being more important than the disease they have. There's a famous Roman, I forget which one, who talked about it. So it's not like it's a new idea, but Engel, he made it official. It entered the pain world in a kind of explosive fashion, roughly 15 to 20 years ago, I think. As we were failing with biomechanical and structuralist perspectives, as we were discovering the limits of looking at the body as a complicated machine, and that the challenge of rehab is to align things and tune it up. This came in as the alternative. So the pendulum started swinging towards what if we pay attention to the fact that pain is a very complicated experience that is influenced by all kinds of psychological and social and emotional and life factors, that it's not just about the body as a machine. And that pendulum swing was surprisingly hard. it was a very strong and rapid push towards let's start treating people like the key to their pain is between their ears, basically. And it swung too far, I think. It swung too hard and too far. And we skipped right over what I think is the most important thing. We went straight from the bio part of biopsychosocial is still important. It's part of it. We went from a bad version of bio, which was simplistic structuralism, just treating the body like a machine, and skipped over the part of the bio that actually matters, which is the wet, messy stuff, the biochemistry, the immunology. We just virtually ignored that and went instead to let's go crazy with the psychosocial stuff and just focus on that. And that's, so the two problems are the overemphasis on the psychosocial, and at the expense of more nuanced, higher quality attention to the bio.
Do you think currently the psychosocial is what you mentioned that the bio was initially, where it's too simplistic of the psychosocial, and it's also not appreciating the messiness?
Mm-hmm. Right. Yeah. If you look at, each part of the BPS, we have a long history of oversimplifying each part of it in different ways for different reasons at different times, but never really embracing the complexity of any aspect of it. The psychosocial, the main way that it's been applied is, I think probably the most common and familiar form is now being denigrated as pain-splaining. Technically, pain neuroscience education, the idea that if you talk to people about how pain works, and you de-emphasize a lot of the fear-mongering that we used to do, and instead talk about how pain is weird and it doesn't necessarily correlate with damage. That's pain neuroscience education. But all the time these days, I'm seeing that referred to as pain-splaining, which is a direct reference to mansplaining, suggesting that pain-splaining is routinely in practice tedious and patronizing. And that sucks. Nobody wants that. And yet that's clearly what has happened in practice. Don't get me wrong here, and this is an important caveat I should get in here. The industry and the world is still overwhelmingly structuralist, which is my one-word way of saying that we overemphasize the biomechanical and the simplistic and the treating the body like a machine, especially one that has alignment problems. That's what I mean when I say structuralist. The industry is still thoroughly rotten with that. After 50 years of modalities that were devoted to that and certification schemes that were devoted to that, it's really hard to actually move on from that. So in a way, this all this talk about the biopsychosocial, we're talking about a nerdy minority of professionals who are really keen on moving into the future and away from structuralism. But there's enough of them out there. There are enough professionals who are nerdy and progressive that it's kind of amazing how often I hear from people complaining about pain-splaining, about patronizing and tedious overemphasis on the effect of the mind on their pain. And I've even encountered it. I've experienced it. I had a very clear medical problem a few years ago that was extremely hard to diagnose, eventually was diagnosed. But in the meantime, I had a physical therapist who blamed it all on sensitization and did a lot of pain neuroscience education with me, which was ironic because I was already writing about it intensively at the time. And that physical therapist had no time or patience for any diagnostic investigation. As far as they were concerned, I was sensitized and that was it. That my entire problem was that I had become too sensitive to, essentially I was hallucinating pain, would be perhaps the unkind way of putting it. But that's the idea, that perceptual amplification was the whole problem. It wasn't. I had a medical problem, which was eventually diagnosed, and my symptoms went away as soon as the problem was fixed, and it was fixed relatively easily. That is the number one danger. That is the big downside to this, is if you put too much emphasis on the psychosocial, you miss the complex and nuanced bio, and there's plenty of that. Bodies are amazingly complicated and prone to an unbelievable diversity of failures and pathologies. It's ridiculous how many different ways we can hurt. And we need, as much as we need some attention to the psychosocial, we desperately need just never-ending education in the biological details and complexity.
Let's use a specific example. So in the email, when we were discussing the potential idea of Achilles tendinopathy as how a better idea of the reality and the messiness of the whole model and more importantly, the biological in this particular example. So do you want to dive into how this could relate to something like Achilles tendinopathy so people can actually picture what you're describing?
Yeah, you've given me a good challenge there, because it's psychosocial factors are much more fashionable in the context of unusually complex, persistent, or disordered pain, like your chronic back pain, your irritable bowel syndrome, fibromyalgia, CRPS, etc. The relatively straightforward injuries like Achilles tendinopathy, they are much less likely to get treated like a psychosocial problem, but it does happen, and you can see much more of that with some, like a good contrasting example would be anterior knee pain, which is quite a lot more complicated than Achilles tendinitis. So basically, the more complexity there is, and the harder something is, and this is important, the harder something is to diagnose, the more likely you are to see a psychosocial perspective introduced as a kind of a crutch. I'm not sure what to do with this, so let's talk about sensitization instead of what's actually wrong. But all these conditions, there are hidden depths, and tendinopathy is, impressively complex. But superficially, it is a pretty simple condition. So you don't see the biopsychosocial perspective applied to it quite as much. But there are still some good examples of how the psychosocial gets overemphasized. So I would say that one example of that is excessively aggressive load management, progressing too fast. And that would be, in this context, it'd be rationalized by prioritizing the patient's emotional urgency to get back into the action, and maybe too much concern about deconditioning in the short term, not respecting the bio, failing to respect the fact that tissue has load limits. You can only do so much of it with it so quickly. There's, of course, there's, especially in America, there's a pretty gung-ho attitude towards, there's a gung-ho culture, a no pain, no gain culture, which also contributes very strongly to aggressive load management. But more and more over the last decade, I've seen intense rehab programs justified by, the most important thing is that this person gets to do what they want to do. And that's so important that it will modulate their pain, right? That their enthusiasm will override their inflammation, which is a bit much. There's some truth in that, but it's the icing. It's not the cake. The cake is still the bio. It's still an injured tendon. And I mentioned, for example, it's a great specific example of neglecting the subtlety of the bio. For a long time now, a lot of professionals that I would put in this category of nerdy progressives have been pretty smug about the idea that actually tendons aren't inflamed. And that's why we call it tendinopathy and not tendinitis anymore, because it's not inflamed. This is a perfect example of neglecting and oversimplifying the bio, when there's still plenty for us to learn and understand about the bio, because tendinopathy absolutely involves inflammation. And this has now been clearly shown. I think I suspected it long before it was shown. This is why immunology gets involved. Inflammation is basically synonymous with immune function. And immune function is dazzlingly complex. Things can be inflamed in lots of different ways, basically. And persistent tendinopathy definitely involves persistent inflammation. So you've got all of these professionals out there who are saying, your tendon isn't really inflamed. It's chronic because of perceptual amplification, sensitization, central sensitization, psychologically amplified. And that's the real issue. And if we just get you doing what you want to do and feeling confident about it, you'll be fine. And I think there's some truth in that, but it's never going to actually override the fact that there's that tendon tissue is still in trouble. So there's one example of how the psychosocial perspective might get applied to and abused in the context of Achilles tendonitis.
How would you offer a better explanation if it was a clinician working with a patient that is suffering or experiencing a pissed off Achilles tendon? Is it just being broader in the explanation for what factors may contribute or what components there are outside of the sensitization aspect and including things? There could be an inflammatory aspect, or there could be whatever it is. Is there a better option you have for the explanation that clinicians can use for that specific example?
I don't think I have any issue with most of what's being explained to patients. It's just a matter of proportion and emphasis. I think load management is, the heart of most rehab, and that's where the emphasis should be. I'll use the icing and cake analogy again. Nothing wrong with talking to people about the fact that how you feel about your bad tendon is relevant, and the panicking and catastrophizing and being really scared of the prognosis probably isn't going to help. I'm fine with all of that, but I still want most of that discussion to be about the load management. How do we get that tendon back to homeostasis is more important in most cases, I think. So that's where I would put the focus.
As you said, this example tends to be a little bit more black and white with some of the treatment, but there's still unknowns and uncertainty and gray. But for the things that you alluded to that are even more put in the bucket of more psychosocial, with a chronic fatigue syndrome, IBS, fibromyalgia, whatever it is, how does the biological component, how can that be better integrated and less shifted over to the psychosocial?
Number one priority is just to have profound humility about these conditions and understand that we almost certainly don't yet understand the bio. And that's much easier, hopefully, now in the aftermath of the pandemic and the lesson that we are all being taught by long COVID, which is now, the most prominent example of a post-viral syndrome that we've ever seen. And that hopefully teaches us to be very careful about assuming anything about what's going on with the bio. And then, the corollary of that is, don't assume that it's psychological. The biggest concern with psychosocial factors mattering is that while that's true, and they do, it constantly gets dumbed down to pain is psychosomatic. And with complex conditions, with biology and pathology we just truly don't understand yet, it's very dangerous to assume that the issue is psychosomatic. There's also a lot of conflating psychosomatic pain with coping. So how do I want to put this? There's pain, and then there's suffering. And we tend not to separate those. And a great deal of the psychosocial concerns suffering, how we feel about our problem and our pain, rather than how much sensation is there. Those things get mixed up all the time. And we could talk endlessly and productively with patients, and this is what a good, for instance, a good occupational therapist would do. You can talk a lot about better coping and how to deal with the suffering without ever touching on pain is psychosomatic. But you often, don't see that distinction being made, and patients are just routinely left with the impression that it's all in your head, right? That the therapist is ultimately, no matter how many pretty words they surround it with, no matter how they try to sugarcoat it, they're left with the impression that the clinician thinks that it's basically a psychosomatic problem, a psychological issue, and the biological, the impressively complex biology is just basically ignored because we don't know. We don't know. In so many of these conditions, we just simply don't understand them. So what are you going to do? You can't talk about the bio when you don't know the bio. So you end up talking about the role of the mind instead. And next thing you know, you're overemphasizing it.
Is there anything else in this general topic that you feel like we haven't discussed or that you want to elaborate on? Obviously, there's so much, but for this, what's been on your mind as of late with this biopsychosocial? Anything else? Or do you feel like we kind of touched on most of it?
I think we've touched on some great themes. Boy, I don't, off the top of my head, I don't have a sense of any key point that I've neglected. Maybe I haven't used the word gaslighting yet, so I've talked about it indirectly, but maybe I'll throw that in at the end here. I was kind of just talking about it without saying the word gaslighting, but this is the greatest danger. Is that clinicians will talk to patients if they put too much emphasis on the psychosocial. It basically, you're treating your patient like they might be a little bit crazy, like they aren't really experiencing what they're experiencing. If you imply that their pain and or their suffering is essentially hallucinatory, that there's no real signal, that it's all amplification and sensitization, people can feel that can be really emotionally challenging for people, because let's just take it for granted that lots of those people have a very real pathology, and they're going to have pain and they're going to suffer regardless of their mental attitude. And telling them otherwise is kind of awful and gaslighty. Obviously, gaslighting is a term that's been probably overused and abused in the last few years, but it is useful here. If it isn't actually gaslighting, it's a good analogy. It's like gaslighting to overemphasize the psychological factors for someone who, very, very possibly has something quite distinct wrong with them. A nice example just popped into my mind. Shall I add that? One of the toughest, one of the most controversial conditions is post Lyme disease syndrome. We learned something about that condition a while back. And it's hard to overstate the degree to which these patients have been exploited by quacks and dismissed by skeptics. Lots of skeptics have had the wisdom and humility to say, I don't know what's wrong with these people. Clearly there is something wrong with them, but I don't know what the hell it is. But it's been extremely common over the last 20 years for skeptical professionals to just blow it off. It's like, there's nothing wrong with you. You can't possibly still have something wrong with you 3 years after a Lyme infection. Well, we learned something about Lyme infections just recently, which possibly explains the entire phenomenon, or certainly part of it. We now know that the organism that causes Lyme disease, I can never pronounce the name of the bacteria, I'm not going to try. That little wee beastie poops out a toxin that gets trapped in people's joints, and we can't clear it. So even after the bug is gone, we pretty much literally have poisoned joints. Tends to accumulate in the joints. And the immune system attacks and attacks and attacks, but it doesn't have the biochemical hardware to deal with this contamination. And so it's very, very likely that this is why some people who have Lyme disease are still suffering years later, because they've been poisoned and there's nothing that the immune system can do about it. And we also don't know how to get rid of those toxins. So that's an amazing example of a condition where patients get dismissed as a bit crazy, when in fact there's something very clearly pathological going on. And we now know that. We have some clarity and insight into that we simply didn't have. I think that study came out like 3 years ago. So until 2020 or something, all those years, we just had no clue at all. You could just guess. You're just like, well, there's probably something, but who knows what. Now we know at least one key piece of that puzzle, and everyone who ever gaslighted one of those patients, I hope, is feeling very sheepish about it.
What about in the scenario with some of these longer term conditions or chronic pain? And one in particular I'm thinking of is the weird nature diagnosis of FMD, functional movement disorder, and still a lot of the unknowns with that diagnosis. And my understanding, a lot of the treatment is a move away from kind of identifying with their diagnosis and progression towards valued goals and activities. How do you balance the reality of maybe some biological and psychosocial, just the diagnosis itself, versus over identifying with it and having it just stop someone from living their life or maybe halting progression?
Over identifying with what?
With their said diagnosis.
The biological. Regardless of what's going on with the biology and pathology, there's always a coping challenge. So let's say that you've got a diagnosis where, it's sort of analogous to, being told you've got 6 months to live. It's strong, it's intimidating, except it's just about pain. You're going to be in pain. That's, you're probably going to have a bunch of pain. Let's say that that's the diagnosis. That could certainly lead to some paralysis. The idea that you can't change the sensation. But there is still potential to change the perception of it and the effect that it has on your life emotionally. That's, for cases where there's strong reason to believe that the pathology isn't very treatable and the pain isn't very treatable, which is, pretty common, actually. A lot of chronic pain is, notoriously difficult to treat. There's first of all, there's almost always some hope of better treatment. But then there's also just always a ton of opportunity to reduce suffering and to cope better. And then on top of that, there's the hope that better coping, less suffering will feed back positively into the biology and the sensation. To this day, nobody knows whether or not that actually works. You see this a lot with the psychotherapeutic approaches. In the clinicians who go directly for the psychosocial by design, it's their profession, it's their, it's what they're all about. They routinely disavow that they're treating pain. They don't necessarily think that what they're doing is going to directly help with pain. But if you interrogate them, you find that they almost always believe that better coping is a kind of pain treatment. That not only will it reduce suffering, it will then feed back into the pain equation and reduce the perception of the pain's intensity and actually reduce the pain and give you less to cope with. This is rarely stated clearly. This is rarely said outright. And, the sort of typical, for a psychotherapist, for a counselor or psychologist or psychiatrist, most likely they would say, no, we're just doing coping. We're just helping you deal with the pain, not trying to treat it. But if you keep talking, you find that they really do hope/believe that that will have a feedback effect on the pain itself. No one knows if this actually happens, which drives me nuts because it's a very common assumption. It's also used to justify more and more psychological intervention. That assumption that it's going to help with the pain ultimately, indirectly, is used to say, well, then this is a good direction to go. Let's keep doing this because it's got that big side benefit. Except we don't actually know that it has that big side benefit.
Yeah, I guess an example in the rehab world, or maybe something that I'm guilty of, is if oversimplifying the progressive and graded exposure to load will maybe desensitize their specific joint or muscle or region of their body that doesn't feel good and that's in pain, and that having a higher ceiling of capacity for daily activities or for tolerating forces will decrease their sensitivity response. I don't think that's always the case. So I think that's maybe a parallel example from the rehab side and compared to kind of the psychology side.
Yeah, absolutely. And that refers back to what I said about Achilles tendinitis earlier, that you see psychosocially justified aggressive rehab, basically with the hope that how the patient feels about it is more important than how the state of their tendon. And that if they get to doing what they want to be doing, that's going to feed back and help the problem and give you less of a problem to recover from.
Zooming out, as we kind of wrap up this podcast, zooming out to how much time you've spent looking into all the topics and researching and realizing there's just so much uncertainty, and you, like you said, with certain topics, you're more and more on the fence, and it's hard to take strong stances the more you realize you shouldn't. Do you have advice for clinicians and students in these fields how to potentially go about that process or be more open-minded and kind of ride that fence more often?
Yeah, I thought about this a lot before the interview because it's a tough question to answer. It's sort of everything and nothing. I have a ton of ideas, but it was hard to find ones that stood out. But I did it. I came up with some ideas. The first is to assume that the truth is highly elusive, to make that your baseline, and more specifically, that conventional wisdom is usually wrong. One of my favorite podcasts right now is You're Wrong About, which examines culturally famous and notorious events and characters. And the story is almost always the same in outline, which is that whatever you thought you knew about this, it's wrong. Whatever the mainstream story is, it's wrong. And I've come to believe that this is just a general principle in any complex field, is that the conventional wisdom is virtually guaranteed to be wrong. Crankery and quackery are the rule, not the exception, and they can be quite sophisticated. So it's really important to always try to find out who disagrees and why. So any idea that you encounter, try to learn something about who would disagree with that and what are their motives for disagreeing with that. Speaking of motives, bias identification, figure out your own. We're very fond of figuring out and attacking other people's biases. It's really important to know your own bias, which isn't necessarily to say that it's wrong to have a bias. In fact, it's not. It's just you got to keep an eye on it. You got to know where you're coming from when you absorb information, and how incredibly powerful the force of hearing what you want to hear is. Like maybe a great example of this in recent history, relevant to the psychosocial theme, is earlier this year we had a very good news study about cognitive functional therapy for back pain. Made a big splash, a lot of people very excited about it. And I kind of was blown away by the degree to which I accepted the idea that it was a good news story uncritically, because that's what I wanted to believe. I absolutely wanted to believe that CFT is great therapy for back pain, largely because it's extremely similar to what I've been recommending for many years. And it just, I was amazed and impressed by how easily I slipped into agreeing that it was good news without really thinking about it, without stopping to ask, is it a good study? What are its flaws and limitations? That's why you got to know your own bias, because that's the mechanism by which we fool ourselves so easily, is that we just soak up anything that we want to believe. Last point, don't trust promising studies. We are awash in them. Speaking of the CFT study, we are drowning in promising studies. An interesting difference between the CFT study and so many other promising studies is that study was actually really high quality in many ways. It was an excellent, rigorous, well-designed study in many ways, done by a competent team, etc. The main reason I say don't trust promising studies is because basically everybody underestimates the degree to which we are drowning in junky papers, junky little trials, and they basically exist to pad people's resumes and not actually answer scientific questions. So almost anything you find that looks like good news about an intervention, it's probably just hasn't been studied well enough. And this is a massive modern phenomenon that has evolved over the last 20 years, especially the last 10. The scientific publishing industry is just absolutely a disaster right now, pumping out literally tens of thousands of studies that run the gamut from merely weak and underpowered all the way to fully fraudulent and everything in between, whole new categories, the whole predatory journal thing. It's bonkers. But basically the bottom line is anybody can go to PubMed and search for anything at any time and find a few little studies that seem promising. And they're not. They never are. They're not worth anything. So that's a really important point about how to critically evaluate this stuff.
I have two thoughts there. Well, one's a question, but the thought was going into PubMed and finding anything. I chatted with a guest. It hasn't come out yet, but Sarah Lord Ferguson, who I believe is also in Vancouver. She's a physio and a lecturer, and she wrote about this editorial on should we give patients what they want, this kind of ethical conundrum. And a lot of it is the dynamic of if you want to be evidence-based, what does that even mean? And you can go on and find something to support whatever the patient's wanting on PubMed. And that's the concern of how do you truly determine what is high value and high quality care, and then how do you sift through research that supports anything. So that's thought number one. And then question with the CFT, we had the authors on, Peter Kent and Peter O'Sullivan, for episode 100, and I am curious, that initial response you had of your bias, how did that change over the upcoming days and weeks, or is it still strongly supportive of that paper, or did you find some flaws or kind of pull back your initial strong support?
Yeah, I pulled back my own support, and I also discovered that I had a lot of colleagues who were who had significant concerns as well. I started talking to people and discovering that not everybody thought that it was a clean win. I'm savvy enough, I've been in this business long enough that I more or less instantly recognize the symptoms of my own enthusiasm and my bias at work. Anytime I'm excited about a piece of science, this is a real drag. I can't just be excited about science anymore. The second I recognize that I'm getting excited, I'm like, oh, what's wrong with it? How am I screwing this up? Do I dare actually be excited about this? Probably not. I'm sure there's something wrong with it. So almost right away, I realized I better check. I did an initial blog post that was just like thoroughly positive, like, woohoo, yay, with just the token acknowledgement that I will return to this more thoughtfully later. But at the moment, it looks great, doesn't it? And then I just went to work, and I started looking at the paper and reading it carefully and thinking about the limitations and the flaws. And long story short, there are some. It's good. Maybe it's legitimately promising. My thing with promising is that almost all studies that claim to be promising or are touted as promising are not actually promising. So I put scare quotes around promising all the damn time. But maybe this is an example of a study that actually is promising. But I think my take on it now is that it's only promising. It's not a huge win for CFT. It was an important study, but it was only the beginning of what we need to do to find out if that approach to therapy for back pain actually is efficacious. And it's really in that, there's a ton to say about this study, but one key point is that it wasn't designed to be a study of efficacy. It was what we call a pragmatic trial. It studied effectiveness as opposed to efficacy. We don't know what the active ingredients are in it. We don't know if the good result was an artifact or due to doing something in a very specific way or something else entirely. That wasn't even, we didn't even realize that was an important part of the equation. So there's a lot more work to do on CFT. I've got a big blog post written about this. I haven't published it yet, but that should make an interesting splash when it comes out.
To the efficacy point, is it possible to sift that out with so many factors?
It's hard, but yes, it is possible. It just takes the kind of science that rarely actually gets done in this field. It's analogous to trying to figure out what nutritional interventions are good for people over the long term. There are so many confounders. It's such a complicated equation. The causality is really difficult to establish. And if you think about it, efficacy trials, that are designed to show efficacy, are basically about causality. They're, does intervention X cause the relief? And those are just really hard to do. And for the same reason that we still have, nowhere near enough answers about nutritional interventions, we probably won't get a clear answer on this one for a long time either. But it is absolutely possible in principle. And by the way, there is a controlled trial of CFT coming. A placebo, I don't know about placebo, some kind of sham. They're doing some kind of efficacy trial instead of a pragmatic trial.
Any current major projects, it's probably a variety, but anything currently right now that you're working on that you want to discuss or promote within pain science?
I want to discuss and promote very different things. Let's see.
Let's say promote.
Yeah, sure. Well, we're getting near the end of the interview, so time for a plug or two.
Sure.
I'm most active in a way. My newsletter and blog has almost taken over the website. It used to be that I had a library of what I called featured articles, which are actively maintained, and the blog was a bit of a sideshow. It's more of just like a director's commentary, news and highlights and little things that I'm up to, keeping basically showing that the lights are on. Well, the newsletter and the blog has become more and more important. Blog posts are getting bigger and bigger, and I now have a membership program. So for all the keenest nerds, both patients and professionals, I have a membership program where I deliver extra content, and my my blog posts are out of control. The performance pressure now that I've got people who are paying for delivery of content, I'm doing way more for the blog. So anybody who's interested to see what I'm up to lately, go to the blog, painscience.com/blog, subscribe for free, or just join up right away and get extra blog stuff.
I think I'm a member. Isn't it only $5 a month? I'm paying $5 for something on Pain Science, and it's been great.
Yeah, that's my my better tier. I have 3 payment levels: $3, $5, and $10 per month, which I call good, better, and awesome.
very affordable, either of those 3 tiers.
Yeah.
Any other final thoughts before we fully wrap it up, Paul?
I'm all out at the moment.
Sounds good. Well, this was an amazing conversation, and I want
I
to
hope
thank you
so.
again for coming on and just for all of the amazing work you are currently and have been pushing out.
Thank you very much, Chris. Appreciate that.